Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Well, hello everybody, and welcome to this live edition of Doc Talk with Monument Health. My name is Mark Houston, and I'm happy to have Dr. Tuma with me today, who has been on a handful of episodes. You're a pro at this point, right? It's pretty easy. We're going to talk about a condition today that it's more common, I think, than people realize, and it kind of flies under the radar until it ends up being a real problem, I think. So like I said, our guest, Dr. Joseph Tuma, interventional cardiologist with deep expertise in coronary and structural interventions and peripheral vascular disease. So if you've ever had something like leg pain, if you've had wounds that don't heal, or we're just told maybe that you have poor circulation, this is going to be an episode that you're going to want to listen to. And before we got started, Doctor, I asked, in this entire building, we have thousands of people here at the Stock Show right now. And I was curious, how many people do you think walking around here today might unknowingly have something like this?
Yeah, so statistically it'd be 10 to 20% of people have, some version of peripheral vascular disease.
Right.
And, a lot of that, the majority of that's actually asymptomatic, not causing symptoms. And, in that 7 to 8% probably do have some symptoms related to the disease, and they may or may not even know what those symptoms are. So hopefully we can kind of go through some of that and educate people.
Well, let's start simple with this right now. When people hear the term peripheral vascular disease, it really does sound intimidating, I think. I mean, those are a bunch of big words that sound scary altogether.
Right.
So what exactly is it, and how does it differ from heart disease?
So, really, they're very similar. The mechanism is the same. Basically, what it is plaque buildup, cholesterol plaque buildup in arteries other than the heart.
Okay.
So that's the easy definition of peripheral vascular disease. But the mechanism, the process is the same, where over time, oxidized cholesterol called LDL gets deposited in the wall of the artery. That can start to calcify and limit blood flow to the various parts of the body. So the legs are probably the most common area that we deal with, but it can affect the kidneys, it can affect the organs in the abdomen, carotid arteries, the arms. So just anything that's not the heart.
Well, and you mentioned LDL, and I think when a lot of people go in for their yearly physicals with their doctor, that's always a big number that people pay attention to when they get their blood work back, right?
Right.
And obviously it's a number we should pay attention to when it comes to this.
Right. That's really the mediator of plaque buildup in blood vessels is LDL cholesterol, which stands for low density lipoprotein, a small molecule that has a tendency to get deposited in the wall. It's called the medial layer of the artery, and over time eventually starts to kind of encroach on the lumen. It gets narrower and narrower and narrower, and then over time your body starts to heal that and calcify, and that's the healing response. And so 5 or 10 years down the road, which was something that was not causing symptoms, starts to limit blood flow, and then people are going to start to have symptoms.
So LDL that's what they also consider, that's the bad cholesterol, correct? You want the HDL to be higher.
Right.
Well, who tends to be most at risk then for this disease, this peripheral vascular disease?
Yep, it's the same, the same risk factors as coronary artery disease. So people that have high blood pressure, people that have diabetes, people that have high cholesterol, either a familial version or, due to diet and things like that. Sedentary lifestyle, poor diet, things of that nature, cigarette smokers.
I was going to say, you didn't say smoking yet, and I knew we were going to get there.
Saving that one for last.
Right.
Yeah.
Well, are there lifestyle factors for this? I mean, you did mention some of those. Family history, does that stuff move the needle on this too?
Oh, big time, yeah.
Okay.
Family, and a lot of that is family history. It's really what it is how your body processes cholesterol.
Okay.
And so, some people can have a super high LDL, but their body is very efficient at processing it, so it doesn't get deposited in the wall of the arteries. So we're kind of learning more about that right now, and that's one of those areas of investigation is the various subtypes of LDL and trying to target exactly the ones that they get deposited in the wall of the artery. So,
well, we have, like we kind of started the show a little bit here, we have a lot of people that are walking around today that chalk up a lot of leg pains that they have to just, I'm getting older.
Right.
Or, we have farmers and ranchers here, and they're on their feet all day long.
Right.
And it takes a lot to get them into a doctor.
Yep.
If they feel that leg pain, they're thinking, well, that's just I've worked my entire life really hard,
right.
20 hours a day. So what are some of what should they really be paying attention to then, these signs and symptoms that might actually point to that disease?
Yeah, and in peripheral vascular disease, it depends on the vessels that are involved. So the legs are the most common, and so typically what it's going to be is cramping pain in the muscle that occurs with walking, and it gets better if you stop moving. So that's kind of the basic definition where, you don't have to change position. If you go a certain distance, a muscle cramps up, you stop walking, the muscle cramp goes away, and you can walk again. That's usually going to be a blocked artery. If you have to sit down and lean forward, a lot of times that's a spine problem. And so, we call ambulatory pain with walking that gets better with rest. The term we use for that is claudication, is the name. So if you have that and it's, getting worse and worse and you're starting to notice you can't do as much as you used to do, that's a clue that there's very likely a blockage somewhere.
And we mentioned, of course, like wounds that don't heal too.
Right.
Some people, it seems like you get a bruise, you get a cut. Can it be anywhere on your body, these wounds that happen, that you notice are like, well, wait, this is really taking too long? Or is it still kind of in that leg area?
It can be. It's much, much more common in the legs and the feet, really, in particular the toes. The feet and the toes, and, it's a spectrum. It goes from pain with walking that gets better with rest, that's claudication, to what we call rest pain, where every time you lay down in bed at night, if your legs start to cramp up on you and burn, you're basically losing the effect of gravity, pushing blood down. And so people will dangle their leg over the side of the bed to get blood flow. And that's one of those things that's kind of where it's progressed now to the point where it's kind of an urgent situation.
Yeah.
The final stage is when people start to have skin breakdown. And there's just not enough blood flow and the skin starts to break down and ulcerate. And so, obviously that's kind of an urgent situation where we need to get blood flow to that foot, or, you run the risk of amputation. So.
Well, how common is this really then? Is it something you're seeing more often in clinic than you used to? Is it becoming a bigger deal, or is it always kind of been around, and now we're recognizing it sooner and being able to inform people so they recognize it sooner?
Yeah, I think both. I think we actually do a much better job of awareness, so people know what claudication feels like, what's the difference between, like you said, I'm getting older, or claudication. This is an actual clinical problem. So I think we do a better job of educating people, but as things like diabetes have, it's just become more and more and more common, peripheral vascular disease increasing in frequency. So we see more of it, and what's unique about where we're at is we tend to see people later in the stages of their disease. We see the people with rest pain, with ulcers on their feet.
Is it just because they're just not paying attention to it, or why is it? Why are you seeing it later here?
I think a lot of it is these people work hard. They don't want to take time out to go see their doctor. I think sometimes it is under-recognized. The patient population that's kind of in our area, high prevalence, high frequency of diabetes. So it's a lot of different things. But, I think people knowing what those symptoms are is really, really important to catching it when it's early, because it's much easier to treat when you have a 70 or 80% blockage than when a whole artery is blocked off.
Okay, so let's talk about somebody that comes in early and you catch it right. Catch it optimal time, right?
Yep.
So then what are the steps, what are the medications specifically that are used to get it when it's treated early?
Yeah. So if people are just having the claudication, the cramping pain, but they're still able to do all the things they want to do, their activities of daily living are normal, we treat that with so we use diet, medications, and exercise, basically. So, low cholesterol, low saturated fat diet. We try to get people to walk a minimum of 40 minutes, 7 days a week.
So even though that pain's there, walking's important with this if it's caught early. Okay.
Yeah, you can walk to the pain, rest, and then keep walking.
Okay.
Yep. And then the medication. So we want your LDL cholesterol less than 70. We want the blood pressure to be well controlled, 130 over 80. Diabetes to be well controlled with a variety of medications that are out there. And And then, optimal diet and exercise. If you're a smoker, we encourage you to quit smoking. So things like statins are the mainstay to lower the cholesterol. Okay. Lipitor, Crestor are the big ones. The variety of blood pressure medicines that are out there. And then there are a number of blood thinners that we use. So aspirin, everybody knows what aspirin is. There's one called Xarelto or rivaroxaban. So there's a study called the Voyager PAD trial, which shows a pretty significant reduction in peripheral vascular events, but also cardiovascular and stroke on this medication, the rivaroxaban, which is a blood thinner.
Right. So, well, that's got to be exciting. I mean, it's got to really help when you can find these medications that kind of go and like, well, hey, I'm going to do this too. I'm going to fix this over here as well, right?
Right, and it makes sense because it's all the same process.
Yeah.
Right, it's hardening of the arteries, cholesterol deposition. So it would make some sense if you're improving peripheral vascular outcomes, you're probably going to improve cardiac outcomes and improve stroke risk. So
when you talk about statins, a lot of people, I mean, that's got to be one of the most prescribed medications.
Yeah, it is. Yep.
For treating cholesterol specifically. What does a statin do in the body? How does that fix what's wrong?
Yeah, so it's called an HMG-CoA reductase inhibitor. That's the long word, which just means
that's why you're the doctor.
Yeah, which just means it kind of inhibits the pathway to the development of LDL cholesterol. So it kind of blocks the conversion of other types of cholesterol to LDL. The other types are much easier processed and eliminated by the body.
Okay.
And so that's how it lowers the LDL. So
now, if the medications aren't working, the exercise isn't working, you're eating better, you stop smoking, but it's still progressing.
Yep.
Procedure is obviously the next thing, and that's the word that you probably don't want to hear the most when it comes to this, right? Does every patient with peripheral vascular disease eventually need surgery, or can it be treated the rest of their lives without it?
No, we have really good outcomes as long, with non-interventional type procedures, whether it's a catheter-based intervention or surgery. A fair number of people, we can get them by, and they have a reasonably good quality of life with medical therapy. Mm-hmm. But again, it's diet, exercise, stop smoking. I mean, it's kind of all of that stuff. So we do have a fair amount of success with the conservative, or what we call the conservative approach, medical therapy and exercise, basically. So.
When you need a procedure, then what does that look like?
So, in this day and age, 80 or 90% of the time, we can fix it with a catheter-based procedure.
Oh, okay.
So where we go in and puncture an artery with a needle and slide a long hollow tube about the size of a piece of spaghetti, a catheter, and we can thread a wire through the blockage, and then we have all kinds of devices to clear out the plaque. We can, use a little device that looks like a drill bit and burr it out. We can use a little device to shave it out. We can balloon it. We can put stents in. We can do all those things.
It's not super invasive, what I'm hearing then.
No, most of those people, about 80% of them, it's an outpatient procedure. They can go home the same day, typically. Kind of depending on the vascular territory. The legs usually can go home the same day. The carotid artery, a little more sensitive area we're working on, so we tend to watch them in the hospital overnight.
We keep talking about the legs quite a bit when it comes to this condition. Do varicose veins have anything to do with this?
So they do. They fit under the category of peripheral vascular disease.
Okay.
You can break that into peripheral arterial disease, which is kind of what we've been talking about, and then peripheral venous disease. So the arteries basically take blood to the extremities, the arms, the legs, the brain. Veins take it back to the heart.
Okay.
So if the veins aren't working well, you tend to have swelling, edema in the legs is by far the most common symptom.
So is it a lot of, if you see a lot of that on your legs, if you see a lot of that kind of spider veins and things like that, is that something you should definitely talk to your doctor about? Because it seems like you can have those and, they're just maybe a part of getting older. Is that?
Yeah, they can be.
Okay.
And it's not a bad idea to mention it, and especially if it's getting worse or you have swelling that's really bothering you. There's a lot of different ways we can treat that with very minimally invasive procedures as well. And it does give us a chance to kind of screen for, check a cholesterol, check your blood pressure, and do all these things to kind of see if we need to get more aggressive with medical therapy.
Well, are there other types of peripheral vascular disease? I mean, you mentioned the one we've sort of been talking about, but how far out does that go? I mean, what else is out there like that's similar?
Yeah, what's similar, and I think probably most important, is aneurysmal disease.
Okay.
And so aneurysms are weak spots in the wall of the artery, so they start to dilate. So most common, what most people know about is an aneurysm in your abdomen, an aortic aneurysm.
Yeah.
Those can rupture. It's often fatal when they do. Aneurysms in the brain are another common thing that we see. So that's kind of a subtype of peripheral vascular disease. And that's something that we, are very aggressive about screening. We're very aggressive about treating. We have a very comprehensive program at Monument with our vascular surgeons. And we can, essentially any aneurysm in the body between, vascular surgery, interventional cardiology, and our neurovascular doctors, Dr. John Atazio and team, we can address everything. So
when if somebody comes in with this condition early, like we talked about, do you screen for the rest of this stuff as well, or do you just keep an eye on it and say, look, next time you come back, we want to go maybe a little deeper. We just want to make sure.
Yeah, we usually do screen. So if somebody comes in, for example, with claudication, pain in their legs, we'll do a carotid ultrasound. We'll do an aortic ultrasound. Sure. Yep. So we look for disease in the carotids, which can cause a stroke. We look for an aneurysm, which can rupture and be fatal. And then we screen all the risk factors: diabetes, cholesterol, blood pressure, things like that.
Are there any screens people can do early that kind of can predict whether or not you will have this condition? Is that something that happens with this?
Yeah, I mean, there's a number of screening tools out there. One of them for aortic aneurysms with any smoking history and age 50 or higher, you qualify for a screening exam. If you have a family history of aneurysm disease, you should be screened. It's just a simple aortic ultrasound. There are a lot of screening programs. LifeScreen is one of them that a lot of church functions have. Yeah. Which typically is a carotid ultrasound, an aortic ultrasound to look for aneurysms, and then they measure the blood pressure in the arms or in the legs and compare it to the arms to screen for vascular disease. Okay. Simple. It's very inexpensive. Usually less than $100 to do all that.
Well, this does seem like something that can be, if caught early, very well managed.
Yeah,
I mean that's
for sure.
This doesn't necessarily have to be scary. I mean, you're talking about aneurysms. When people hear that word right away, they're like, "Well, that's scary. That's the worst."
Right.
But again, like you said, if you catch it early, then that's got to make you feel good. Are there new? I always like to talk about the new technologies and the new things that you guys see that come out every year. Right. Are there things down the road that you're getting excited for, or things you have seen coming out in journals or other things that you're?
Yeah, absolutely. The advancements in treatment of aneurysmal disease have been very dramatic. We have two very experienced vascular surgeons. We've done a case here recently, which, believe it or not, was published in a Journal of Vascular Surgery. Excellent. It's a first case done in man, believe it or not. Wow. At Monument. And our vascular surgeons did that case. And so the treatment for aneurysmal disease with minimally invasive procedures, catheter-based techniques, basically from the aorta as it comes off the heart all the way down into the legs. Most of that stuff these days we can treat with a catheter, which is amazing. And it is. And that's a huge advance because surgery for those, open surgery is a big operation. There's the time in the hospital, the recovery, all those things that go along with that. The
complications, all of that can be scary.
And we can do it, our surgical team certainly can do those cases, and we do those cases. But the advancements that have come along over the last few years have been pretty dramatic in the treatment of aneurysms.
So for anybody listening now or that will listen to this podcast when we're done, that maybe is having the thought that, this could be me. What do you want them to do next? If they're hearing this and they're thinking, God, I've got at least a couple of these things he's talked about, what should they do?
Yeah, I think you go to your doctor or your healthcare provider and just let them know you're having these symptoms, and you can even say, I think I might have peripheral vascular disease. Is there a screening test you can do? And again, it's as simple as an ankle brachial index where we check the blood pressure in the arm, we check the blood pressure in the ankle. If there's a discrepancy there, that pretty much makes a diagnosis, and then we can look further. Ultrasounds, very inexpensive, very simple test. Doesn't involve contrast dye. We can do it in the outpatient setting. So really, I think it's just you have to kind of be open with your healthcare provider, let them know what your symptoms are, and then we can order some diagnostic testing to figure it out.
Excellent.
So, yeah.
Well, Dr. Tuma, thank you again for coming in and doing this. It's always great to talk to you when we do these podcasts. Yeah. I learn way more than I probably should, honestly. But I really am glad you came in and did this. And thanks for coming down to the Stock Show. Thank you all for sitting in and listening to it as well. I really appreciate it. And if you have any questions for Dr. Tuma, we would also love to hear them if you have any.
Simple. Anybody have questions?
Anybody have questions? Yeah, go ahead.
Where are you from?
So I'm from Rushville, Nebraska, which is 2 hours straight south of here. Yeah. So a lot of these people here I recognize and know, and yeah, that's where I'm wearing my cowboy.
I was going to say that can't
boots
be Rushville can't be a very big town.
No,
yeah.
700 people or even. I'm not even sure if it's that big now.
Excellent.
So, yeah.
Anybody else have anything? Yeah.
What is something that you've learned from treating these patients that you might have not seen in a textbook or in medical literature that you've learned from treating?
So that's a great question. So the question is, what's something I've learned seeing and treating these patients that may not necessarily be textbook? So it's a very good question, and I think, everybody senses things differently, and particularly peripheral vascular disease. Some people are going to have cramping pain in their legs when they walk. That's what the textbook says. Some people are going to come in and say, my legs are tired. I just get tired. Some people are going to come in and say, my legs ache or my legs are numb. So I think you have to have a kind of a high index of suspicion. Not everybody reads the textbook. And so you have to look at, their risk factors, their cholesterol, their diabetes, things like that. Do a good physical exam. But that's, I think that's one of the more important things is, and it's the same way with the heart. Not everybody comes in and says, I have, heavy pressure like an elephant sitting on my chest. They'll just say, my chest hurts, or I'm short of breath, or my neck hurts, my arm hurts. So, understanding that it's a spectrum and it's variable in how people present.
It's all about really sitting down and really listening to them too.
Yeah.
I mean, that's obviously got to be very important for you guys.
Yep.
Is kind of hearing between the lines a little bit too, I think, when they talk to you, if that makes sense.
Oh, absolutely. I mean, I think too, particularly with this crowd, it's important to have the spouse come in.
Yes.
Because they'll tell the real story a lot of times. So you get the actual story, what's going on. So that's really helpful,
Yeah.
Or they'll sit in the back and shake, no, that's not what's happening. But yeah,
so I'm hearing is go to the doctor with your spouse. If you have a spouse or significant other, go to the doctor with them. Perfect.
But yeah, it's important to sit down and really listen to people, and I'll ask questions like, if you get up and walk to your mailbox, does that hurt? How long does it take you for your legs to cramp? And they say, well, I can go about 100 yards, and then I have to stop. I wait for 5 minutes, and then go again. That's pretty limiting symptoms.
Yeah, it is.
That's not very far.
Right.
So day to day, you wouldn't be able to go shopping. You'd have to.
Yeah,
get a cart.
exactly. I mean, you wouldn't be able to walk around here for 3-4 hours. That would be just impossible.
Right.
Anybody else have any questions? No? All right. Well, thank you, Dr. Tuma. I appreciate it again. Thanks for doing this.
All right.
Thanks, you guys.
Yeah.